The last two speakers today are Drs. Harrison Pope and James Hudson. Dr. Hudson is behind me at this time. Dr. Pope will be joining him for the discussion and the question and answer period. I have a very brief story to tell about these two gentlemen. When I was a resident many years ago, I used to read articles by these people, and I was just amazed at the wisdom and the knowledge that they showed, as well as their compassion for human beings. And so now I'm just tremendously honored to have these gentlemen here with us today. Drs. Pope and Hudson are both members of the Department of Psychiatry. They're associate professors at the Harvard Medical School, and they are the authors of over 200 papers in eating disorders and biological psychiatry. I'd be very honored if you would welcome Dr. James Hudson to the podium. Thank you.
Thank you very much, Dr. Piper. A little over 100 years ago, medical schools in the United States were largely separated from universities. General clinical practice was not based much at all on scientific evidence for efficacy of treatment, and medical quackery abounded and was actually a major public health problem. Not that we've eliminated quackery by any means today, but it was certainly a very big problem in the late 19th century. And to address these concerns, Johns Hopkins University Medical School was established to integrate basic science or science with clinical practice. As one of the founding physicians, William Osler, put it, clinical experience is no substitute for clinical knowledge. Today, we in the mental health profession are facing a similar problem with some forms of the practice of some forms of psychotherapy. As we've learned in this conference, and particularly as Dr. Lindsay highlighted yesterday, one of the bases for recovered memory therapy is the widespread belief that childhood sexual abuse causes adult psychiatric disorders. A second point that he emphasized was that many therapists lack training in basic scientific techniques and how to approach a question scientifically. Today, I'm going to address both of those issues. I'll review the status of the evidence, the scientific evidence, as to whether childhood sexual abuse is a cause of adult psychiatric disorders. And in doing so, I'm going to adopt a formal, structured, and I hope it's not too didactic or too tedious approach, because I'm interested in conveying not only the data, but how to think about the data, how to critically evaluate the types of scientific studies here, and actually scientific epidemiologic studies in general. But before I discuss how studies may be flawed in their design or they're or biased or misinterpreted, let me just start out with 3 points on which there is no disagreement. First, that childhood sexual abuse is a common phenomenon. Second, that childhood sexual abuse can cause great distress to victims. And third, that every attempt should be made to prevent childhood sexual abuse and to offer victims appropriate intervention and treatment. I think this much is agreed upon by most everyone, or should be. However, despite widespread agreement on those points, it is not scientifically valid to leap from this to the conclusion that there are specific adult psychiatric disorders which are caused by childhood sexual abuse. And here, I'm going to give you a hypothetical study, a study that was not performed, but is sort of a prototype of those that are in the literature. Harrison and James found that adult women with psychiatric disorders coming to a clinic were twice as likely to report childhood sexual abuse as women in the community. The authors concluded that childhood sexual abuse helped to cause adult psychiatric disorders. What I'd like to submit to you is that studies done in this type are the entire basis of our scientific data bearing on this topic. In fact, these are the best of the designs that are out there. By understanding these types of studies and this type of data, you'll understand everything virtually that there is to understand about our knowledge base in this area. And so I'm going to focus not on individual disorders and various studies, all of which look a little bit like this, but rather on the structure of these types of studies and what we can say. What we've got in them is a hypothesis of causality, a theory of causation. And that theory can be stated simply, but is actually very difficult, as many theories are, to test. But the simple theory is that childhood sexual abuse causes or contributes to or is a risk factor for adult psychiatric disorders. I've laid that out schematically as A here, arrow meaning caused, B. And throughout my talk, A is going to be what epidemiologists might call an exposure, something like childhood sexual abuse, a factor. B is going to be a development of a disease like psychiatric disorder or some other kind of outcome. And the question really before us with the studies in the literature is, does an observed association between A and B imply that A causes B? In other words, we clearly have observed reported associations between childhood sexual abuse and adult psychiatric disorders. The short answer is no. Association does not imply causality. And if you take away one message from my talk, I'd like you to take that away. So that's all you have to learn from the talk, and now you can sit back and kind of maybe think about things. But the one thing to learn is that association does not imply causality, and I'd like to walk through some of the reasons why. First, in order to test a causal hypothesis, we can break it down into two parts here. One, is there a true association between A and B? We have an observed association, but there are various things that can skew the association, and we might find a sort of false association basically due to flaws in research design. Second, if there is actually a true association between A and B, does A in fact cause B? Turning to the first part, judging whether there is a true association. Well, epidemiologists sort of identify two types of bias which can influence this. They can actually cause one to see a true association when one doesn't exist, and conversely they can result in failure to find an association when in fact a true association exists because of two forms of what we call bias: selection bias, information bias. I'm not going to spend a lot of time here dissecting these terms, but essentially selection bias can occur when the selection of subjects for a study as a case, as a person with a psychiatric disorder in this case, in this instance, or a control, a person without a psychiatric disorder, is influenced differentially by the presence or absence of a history of childhood sexual abuse. And that's a bit of a mouthful, and I'd just like to illustrate it with one of these forms of selection bias, say referral bias. Referral bias might occur in our hypothetical or prototypical study if Harrison and James were well known for their treatment of individuals with childhood sexual abuse, that they had specialized, if you will, in treating victims of such trauma. In that instance, women, say, with depression in the community who were going into treatment, those who had been abused as children might selectively go to Harrison and James for treatment, who hadn't might go to other therapists or other clinics. Thus, just by looking at Harrison and James's clinic, one might get an erroneous impression or a skewed impression that the prevalence of childhood sexual abuse was much higher among depressed women than it would be if you took all of the depressed women in the community at large. Other forms of selection bias can occur. I think in the interest of time, I'll move on, though, to another form of biasing associations, and that is information bias. Information bias can occur when the data from the cases arise or are obtained in a different manner from those of the controls. In other words, the two groups really aren't assessed in the same way. In our instance, one of the things to highlight is the effects of a certain kind of reporting bias called recall bias. In psychology, it's well known there's a phenomenon called effort after meaning, and that is that individuals with a distressing condition may actually look more carefully at their life for explanations of their misery. So that an individual who has, say, bulimia nervosa coming into treatment is likely to have searched his or her life for various possible explanations. And in this context, it may be more likely that an individual with a psychiatric disorder may have thought back on their childhood much more and sort of agonized, how did this come about? What in my childhood experience might have helped to explain this, and might actually recall more experiences of abuse, or even label certain experiences that might not be abusive, labeled as abusive to a control, might selectively, the presence of the illness might color the recollection, say, well, that probably was a little more severe because I have depression now. So, in other words, differential recall or reporting from the depressed patient, say, and a patient without depression may account for bias in these kinds of associational studies. The next form of bias is sort of from the investigator, not from the subject, and that investigators in these studies know who is a case, and they know who is a control, and they might expect, they have a hypothesis that sexual abuse may cause or is associated with psychiatric disorders, and that may bias their assessment in marginal cases particularly. Somebody describes an experience, they might expect that the depressed patient would have had an experience of sexual abuse, might call a certain experience abusive in a case rather than a control, or might probe more carefully. Another form of measurement bias there would be that many times in these studies, the cases have gone through quite a lot of psychotherapy and quite a lot of contact with the researchers, and they have been subjected to a lot of opportunities to probe for this history, whereas the controls have not, and that may also influence the association between the disorders because of differential obtaining of information. But even granting then, let's move on, that there is a true association, that selection bias and information bias cannot truly account for the findings. Can we still, now are we justified in concluding that A causes B? The answer again is no. There are alternate explanations that must be excluded. And this is something that is often, I think it's clear to diagram, but often difficult to appreciate in practice. So what I'm going to do is just walk through sort of a structure here that's initially going to seem somewhat simple-minded, I hope, but lead you to things that become quite subtle, so subtle that they've fooled leading medical investigators and other individuals and led to erroneous conclusions which were later reversed. So there are three possible explanations for an association between A and B, a true association. One is that A causes B. Childhood sexual abuse does in fact lead to adult psychiatric disorders. That's our hypothesis. What do we have to exclude in order to confirm the hypothesis? We have to exclude that B in fact causes A, that antecedents of illness may actually lead to greater levels of exposure, and then the subsequent full-blown form of the illness develops, for example. 3, that A and B are really not related causally, but both A and B are related to an underlying factor C, and that gives rise to both A and B, whereas A and B are really independent entities, only related by factor C. Now, I begin with some examples. This is the example of sort of reverse causation, that disease leads to exposure. Suppose we were to go out and do a study of the use of nutritional artificial sweeteners, Sweet and Low, in Baltimore here. And we found that individuals with obesity were 5 times more likely to use Sweet and Low than individuals who were not. Would we be justified in calling a press conference and alerting to people that Sweet and Low was a new cause of obesity? Of course not. The reason is that people who are overweight use artificial sweeteners in order to reduce the calories in their diet. It's pretty simple here to recognize that B is causing A. A more subtle example is an association between inactivity and heart disease observed in rural farm workers in Georgia a few decades ago. And here it was found that farm workers who were in the fields working had lower rates of cardiovascular disease than did farm workers who had sedentary jobs. It looked on the surface of things that perhaps that would be that inactivity would be a risk factor for coronary artery disease, or activity as a protective factor. And that may well be the case. But in this instance, it was shown that what was actually happening was that people who had taken sedentary jobs, moved out of the field, had in fact developed the early stages oftentimes of heart disease, which led them to move out of the field and into the sedentary job. So it was antecedents of the disease which led to the exposure or the risk factor, in this case, inactivity. In the interest of time, I'm going to skip over the third analogy and go to a consideration of sexual abuse and mental retardation. Sexual abuse and mental retardation are clearly associated. People who are mentally retarded are clearly at risk for having, or clearly have more experiences of being abused than people who haven't. What's the difference between this and sexual abuse and adult psychiatric disorders? Well, there's actually one very clear difference, and that is that there is one epidemiologic principle that can't be violated here in terms of cause and effect relationships, and that is that the effect has to come the cause has to come before the effect. In other words, mental retardation is usually present at birth before any form of sexual abuse can occur. So therefore, we sort of discard immediately the idea that mental retardation, that sexual abuse causes mental retardation. What if mental retardation were a late occurring phenomenon and only manifests itself fully in one's early adulthood, whereas there were antecedent forms of it that were very difficult to detect that might have led to a greater vulnerability into sexual abuse? Then it would be far more difficult. We might be debating this issue quite a bit these days. And here I think it bears remembering that adult psychiatric disorders do have antecedents. Clearly people with mood, anxiety, eating disorders, and lots of conditions are often depressed, anxious, shy, more impulsive, etc., etc. They're different in terms of their temperament as children than are from other children. And part of these differences may result in some sort of be more vulnerable to be prey to being victimized. Now, my next now I'm going to illustrate another causal mechanism, and that's where there is a third factor, confounding factor. Confounding factors can often be subtle, but sometimes they're not. We call the factor C, leading to A and B, a confounder. Now, if we were to do a study of individuals in nursing homes versus individuals shopping in local shopping malls, and try to determine the prevalence of the ownership of Lawrence Welk recordings, we might have a hypothesis in mind, and we might be borne out that individuals in nursing homes might have far greater prevalence of ownership of Lawrence Welk recordings than the shoppers. Would that give anyone here concern that if they received a Lawrence Welk recording for Christmas, that by next year at this time they would be in a nursing home? No. Why is that? They're clearly associated. There's no doubt. I think we could rule out information bias, selection bias. We could be very pure about this. Well, the reason is that both of them are independently related to the confounder age. Age leads to nursing home, is associated with nursing home residents, and popularity of Lawrence Welk is a certain sort of associated in current society with a certain age group. This one you all laugh at because even though you might not have said age is the confounder initially, you realize that something's wrong with this picture. Another picture that wasn't so obvious that anything was wrong was the issue of whether nitrites and caused AIDS. There was an association between inhaled nitrites, or poppers, substances drugs that were used predominantly by homosexual men to enhance sexual pleasure, and the development of acquired immunodeficiency syndrome. Because of this association, it was thought that maybe the nitrites were causing some kind of immunosuppression and leading to AIDS. In fact, some very elegant epidemiologic studies were done to show that this association was there, and elaborate statistical modeling, including fancy logistic regression analysis, confirmed showed that even by trying to remove potential confounders, the effect only was magnified, thus giving people greater confidence in the results. Very shortly thereafter, though, it was shown that HIV virus causes AIDS. And in fact, it was subsequently realized that unsafe sexual practices were risk factors both for AIDS, as we know, and for the use of nitrites. But I'd submit to you that if we had not found the HIV virus, we'd still be debating today whether nitrites were causal factors in AIDS. So again, confounders are not easily recognized and not easily controlled for. And here there are many potential confounders in the example, in the hypothesis under consideration today, that childhood sexual abuse causes adult psychiatric disorders. Of the several possible confounders, perhaps the biggest one that people haven't paid attention to is the effects of genetics. We know actually quite a lot about genetic factors or in psychiatric disorders. We don't know quite how genes work in these disorders, but we do know that there are at least some genetic factors present for the development of mood disorders, eating disorders, anxiety disorders, even certain forms of personality disorder. They don't account for the full effects, at least as people can tell thus far, but nevertheless, individuals who have a certain hereditary predisposition are more likely to develop, say, manic depressive illness than individuals without that. One of the things which happens is that not only are bad genes, if you will, I'll use bad in quote, responsible, at least in part, or causal factors for many psychiatric disorders, but also they are associated with sexual abuse, or in the following manner, that individuals with bipolar disorder, manic depressive illness, or alcoholism are far more likely to be perpetrators of sexual abuse than are individuals without those disorders. An illustration of this and how it might confound a study comes from a study that I'm familiar with in patients with eating disorders, in which eating disorders, women with bulimia nervosa who had been sexually abused as a child, was published from the University of Pittsburgh, and over 50% of the women with bulimia who had experienced childhood sexual abuse had been abused by a relative with manic depressive illness or with alcoholism. So in this case, it's very hard to disentangle the effects of genetic factors from the effects of the abuse itself, since in the family trees of patients with eating disorders, you see high rates of alcoholism and manic depressive illness. And what may be happening is that the eating disorder may at least be in part arise from a genetic predisposition, but the perpetrator's alcoholism and bipolar disorder, say, which led to the abuse experience, may have led to the individual having had an experience of sexual abuse. I go through these sorts of examples in a sort of tedious and didactic way just to show that these factors are very important in assessing epidemiologic evidence and evidence for causality. We've got many, many studies of the Harrison and James variety of an association. Some studies are actually negative and show very little association. But that's basically all that we have at present. We need is 200 more studies of the same type. What we do need is studies that can get at these methodologic deficiencies, can make sure that the associations are not biased, and then rule out alternative causes. And really, given the importance of this particular hypothesis, it certainly does deserve further study. But at present, I would submit that the current status of the evidence is that pending methodologically sound studies, we cannot conclude that childhood sexual abuse causes adult psychopathology. Conversely, we cannot conclude that it doesn't cause it. But at present, this is sort of where it's at in terms of the state of the evidence. And here, at this point, I'm going to conclude. Thank you very much.